So we're going to record our session today. Rebecca, do you mind just pulling that door too? I got a big mouth and nobody wants to listen to me. You guys have to, so sorry about that. We're going to be in cardiology medications for obviously this week and at least for next week because there's so many medications that you need to know as far as cardiology goes, as well as there's a lot of information about cardiology. So what we're going to do right now is we're going to carry on. Now, remember, we talked about oxygen, all right, on Monday. We talked about aspirin, and we talked about nitroglycerin. Here is another mainstay in the treatment of myocardial infarction or chest pain that is of a cardiac nature, and it's morphine sulfate. Morphine is an old drug. It's been around probably since at least the late 1800s. Okay, this is classified as an opiate agonist. Now, who can tell me what the word agonist means? Should be very familiar to you by now.
What is stimulates a receptor to perform a specific action?
Perfect. Yeah, very good. Perfect. That's exactly right. So it turns on the receptor, it causes something to happen. It goes into the opioid receptors in the brain, and what we give it for is to decrease the sensation of pain. Now, one of the things I want you to understand, the body is really pretty amazing, but it can be kind of weird sometimes, is that if you break your arm, if you break your leg, if you're having chest pain from a cardiac problem, the pain that you're sensing is not in your arm or your leg or in your chest. The pain is actually in your brain. Okay? It's actually in your brain. And what opioid receptors do is that it turns off that ability for the brain to sense pain. So when we give a patient morphine and we give it to them in the right dose, now it dampens that, it turns on those receptors, and the patient is not able to feel pain anymore. Now, there's some other things that morphine does that is a really good thing that we will talk about in just a minute, but you have to watch it as well. Most medicines, when you give a medication, has a good side and a not so good side, all right? So we have the intended action and then we have side effects. With morphine, one of the big side effects that we gotta watch is respiratory depression. We'll talk more about that in just a minute. Now, here's the other thing that you want to be really careful about is that morphine can actually cause our blood pressure to bottom out as well. And so how does it do that? Well, first of all, it can cause the release of a chemical called histamine. All of us in here are getting ready to experience the joys of histamine release in just a few weeks. What's going to be happening? That will cause all of us.
Like springtime allergies?
Yep, springtime allergies. You're exactly right, Caden. Good. So the allergies are pollen is in the air. It gets into our nose, gets into our system, and the way the body battles that is that it releases histamine. So we snort, we snot, we cough, we sneeze, and that's the action of the histamine. Now, here's the other thing to keep in mind. When there is a massive histamine release, it causes the vasculature to do this. And that's why morphine can drop your blood pressure. That's a good thing, also a bad thing. Okay? In just a minute, we'll talk about both of those. All right? The other thing that morphine does is, again, remember, morphine works on the brain. It turns off the pain receptors in the brain, but it can also turn off the vasomotor sensors. Now, when we talk about vasomotor, what are we talking about? What do the vasomotor centers in the brain do?
like control vasculature and like your motor function?
And you're on fire today. Awesome. Yeah, you're exactly right. So vasomotor, vaso refers to vasculature, motor refers to movement or actual physical function. Okay? One of the things that you will do as you're moving in through your paramedic test, you will take a psychomotor exam. All right? Now, stay with me because you're thinking, what's this have to do with morphine? Okay? Motor refers to doing. Okay? Psycho refers to, not that you're crazy, but it refers to your ability to think and make decisions to do the right thing. Psychomotor. Okay? Vasomotor, vaso, vasculature, motor, physical, refers to the ability of the brain to send out signals to do this to raise the blood pressure. Morphine will stop that. And now no signals go out. Therefore, now there is no vasoconstriction going on, which reduces our cardiac output, which reduces our blood pressure. There are times when we want to reduce the blood pressure, okay? But there's other times that when we give morphine, we can have a reduction in the blood pressure as a negative side effect, okay? Now, when we're looking at this for this particular patient, hold on just a minute. Let me get my remote to working. There we go. So when we're looking at this, it also turns off the sympathetic nervous system. So it doesn't turn on the parasympathetic. Much like, remember, we talked at the beginning of class that the sympathetic and parasympathetic nervous systems are always at work. They're always bouncing back and forth and back and forth. If you give a patient morphine, what it does is it just simply turns off the sympathetic nervous system. So that means your patient's level of consciousness may drop, their heart rate may drop, their respiratory rate may drop, their pulse rate may drop. And so that's a good thing, unless it all drops too much. And then that is not a good thing. Why do we give morphine? Well, from a analgesic, and make sure you're familiar with that word, analgesic. I will bore you with how many students that I work with around the country. I have a tutoring consulting business on the side, and they don't know what that word means. Analgesic. Analgesic simply means pain relieving. Pain relieving. But it functions as an analgesic to relieve pain. Pain from what? Well, pain from trauma, but we mostly use it to relieve pain from a cardiac origin that's associated with acute coronary syndrome or an MI. What does it do? Well, as it says up in here, we can also utilize it for heart failure and pulmonary edema. What it does is, now remember, when we give morphine, what does it do to the vasculature? Yeah, thank you, Rebecca. It dilates it, okay? What's that going to do to our preload? Increase it or decrease it? Say it again. It's going to decrease it, okay? Why is that good for patients in heart failure or pulmonary edema? Pulmonary edema is the fluid in the lungs that comes about when a patient has heart failure. If you have less blood coming back to the heart, now what you're going to do is you're going to have less blood that will accumulate in the lungs when it gets pumped through for diffusion. Okay? So, again, it's an analgesic, particularly in the relationship of cardiac disease. We utilize it in heart failure to help to reverse pulmonary edema. Let me stop there just a minute. Are there any questions about that? We're not done with morphine, but I want to make sure everybody's clear on that. This is a foundational drug that you need to know. What can it do that is not so good? Well, first of all, it can cause respiratory depression. It can cause your patient's respiratory centers to slow down and or stop. Okay? We've already talked about the fact that it can lead to hypotension, a drop in the blood pressure. If you push it too fast, it will make your patient vomit. Now, here's a little bit of a cardiac lesson in here. We don't want our patients to vomit when they're having a heart attack. Why? When we vomit, does the pressure inside the chest go up or down? You're right. It goes up. We have a nerve that runs through the heart, starts here in the base of the brain, comes down, goes through the heart, and ends in our stomach. It's called the vagus nerve, VAGUS, vagus nerve. When we put pressure on that vagus nerve, it slows the heart down. If we've got a patient that's having a heart attack, we don't really want to slow that heart down a bunch because it can make the heart attack worse. Okay? So when you give morphine, you want to give it slowly. You want to give it, we'll talk about dosing in just a minute, but you want to give it at about a milligram every 30 seconds. Okay? You want to give it really, really slowly. Side effect again is sedation. It can cause your patient to go to sleep. And what kind of problems do we have if our patient is sedated and now they begin to vomit? Yeah, aspiration of vomitus. Aspiration of vomitus. All right. It can make a bradycardia worse. Don't worry about this bottom bullet here because you haven't had enough cardiology to really understand the why of that. But the top four you do need to know. All right. So there are contraindications. What's the difference between an adverse effect and a contraindication? Anybody but Rebecca.
Contraindications mean you should not give the drug in this case, or you should reconsider.
Okay. For the bonus points, of which there are none, what's the difference between a relative and an absolute contraindication?
A relative is a use with caution. A absolute is do not use.
Perfect. I like that. I'm gonna change my my words up. I like that with relative use with caution, and then absolute is you don't use, no way, no how. Thank you. Excellent. So keep that in mind. So our patient has this contraindication. If our patient is suffering respiratory depression or failure, we're not going to give it. Why? So you see, why would we not give this medicine to a patient in respiratory failure or respiratory depression?
Because it's just going to drop it even more.
Good. So yeah, so it's just simply going to make the respiratory problem worse. Okay. We also don't give it to a patient in shock. Why would we not, Ethan? Why would we not give this to a patient in shock?
If someone in shock's blood pressure is already low and they're losing a lot of blood, you don't want to lower it further because that could lead to more blood loss.
Okay, good. So now keep in mind, when we're talking about shock, we're kind of talking about shock in the generic form. Loss of blood is indeed one type of shock, hemorrhagic shock, but in any type of shock, cardiogenic, septic, anaphylactic, or anything like that. So again, remember, it causes vasodilation. The last thing that we want to do is to drop somebody's blood pressure who is already in shock even lower. Okay? Now, what's the problem with head trauma? There's actually two. So, why would we not want to give this to a patient who has head trauma? Going to be a long, boring class if y'all don't chat. Got a couple of you done real well, but let's hear more.
Bleeding and blood pressure decrease.
All right, so we'll start there. So if we have a drop in the blood pressure, we're going to decrease perfusion to the brain. That's not good for a patient with a head injury. Also, remember, causes vasodilation. We got a patient with a head injury, the pressure inside the skull will begin to go up because of swelling and because of bleeding. The last thing we want to do is make the vasculature larger so that it's now beginning to push on the brain tissue even more, raising that intracranial pressure. Here's the other thing. If your patient is sedated, it makes it much more difficult for you to assess them in the presence of a head injury, because one of the things that we want to track with patients with a head injury is their level of consciousness. So if we give them a bunch of morphine and now they're sleepy or they're very lethargic just means maybe they're kind of mumbling. It's going to be difficult to tell, is this lethargy coming from the head injury or is this lethargy coming from the morphine that you just gave? Okay. We have other medicines that we can give that will not affect the brain as much. We'll talk about those at a different time. Okay. Now, what is our dosing regimen? All right. You can give 2 to 10 milligrams. You can give this IV in through a vein. IO is intraosseous. You'll learn this. We have a little tiny drill, fairly large, not long, but fairly large diameter needle. You'll drill it into a bone, either up here at the just below the knee, just above the knee, or right here into the shoulder, goes into the bone, and we can give fluids and medicines that way. That's intraosseous. Or we can give it IM into the muscle. A couple things to remember about when you're giving morphine. Number one, we give it slow, especially if we're giving it IV or IO. Why did I say we want to give it slow? So a patient can begin to vomit. We don't want them to vomit. And again, if a patient's vomiting, again, another reason why we want to stay away from giving it with patients with head injuries is that when we vomit, we increase the intracranial pressure. So number one, we're going to give morphine slowly, okay? Number two is I have never, ever, even though it's within the dosing regimen here, I've never, ever given 10 milligrams of morphine to start out with. I always start out, depending upon the size of the person, between 2 to 4 milligrams of morphine, especially if I'm giving it IV, okay? Because you can give more. You can go up to 10. You can give more if it's not effective. It's difficult, although not impossible, to tamper it down, as we'll see in just a minute when we talk about Narcan. So start out with 2 to 4 milligrams and give it very slowly. If you've got a person that's my size, I tell you, you probably need to start out with about 4 milligrams, okay? If you have a person that is a small stature, not a large person, not a lot of adipose tissue, but mostly muscle, start out with 2 milligrams, okay? And then you can go up. Why do we start out with low doses? Because we want to minimize the potential side effects that we talked about a while ago. We don't want those to take place. Now, in the worst case scenario, let's say that we are now have given our patient, let's say you've done everything that Dr. Young has told you, you've given 4 milligrams, and now your patient is snoring and you're having a problem maintaining the patient's respiratory status. You gave 4 milligrams, the patient is having an adverse effect. First of all, understand, you haven't necessarily done anything wrong, okay? Remember, your patients have not read your textbook, so they don't know how they're supposed to act. So 4 milligrams, even if you give it to a person my size, may go to work really, really quickly, and as a result, now the patient may be having some respiratory problems, their blood pressure may be going down the tubes, they may just look terrible. So what we want to do is we want to bring them back, and we do that with Narcan. Narcan can be used for any narcotic. Now, this is why I told you that you want to start out with a small dose and work your way up. We don't want to use Narcan because generally what happens is when we give Narcan, it wipes out the effect of the pain medicine and the patient wakes up instantly, and guess what else comes back? Their pain comes back. So if we're giving morphine for a patient that's having chest pain, the last thing we want for them to do is to go from a nice sleeping state, although they're having respiratory problems, to now all of a sudden they're wide awake and their chest pain is killing them again. It's going to release catecholamines. It's going to put a stress on the heart, and we're going to make we're going to make the heart attack worse. So what we want to do is and we'll talk more about dosing of Narcan just a little bit later on. So what we want to do is we want to give just enough Narcan, and we can give Narcan either IV, IO, or IM. The most common way is to give it intranasal. So we can give them just a little bit. We don't have to give them the whole vial of Narcan, and watch them while their respiratory status now begins to improve. Even if the patient is still sleeping, but if their respiratory status comes up, you've still done a very good thing in the fact that the patient's not having any chest pain. Okay? We give too much Narcan, it wipes out all of that morphine that you've given, and the patient's chest pain comes back with a vengeance. If they have respiratory insufficiency or respiratory depression, be ready to help ventilate for them with a BVM while you get your Narcan ready. Now, one of the things that happens now, as far as some of the side effects, is remember, I said that it causes a histamine release. So a lot of your patients will often complain of having kind of like a body-wide hot flash, like somebody suddenly turned up the heat, and they feel hot from their face all the way down to their toes. That's a normal side effect of morphine. Why? Because that's a normal side effect of a histamine release. Okay? Nothing to be worried about, but it does come into play there. Again, anytime that you've got an overreaction or an accidental overdose of an opioid or a narcotic, whether you caused it as a paramedic or whether the patient caused it by using narcotics recreationally, Narcan is your answer. We'll talk more about Narcan later on in toxidromes. All right? Let me stop there. Questions about morphine? What does histamine release cause? And
Hypertension.
hot flash and hypertension, two H's, okay? Hot flash and hypotension. Important thing to remember, all right? Another common type of cardiac drug that you will be giving as a medic on a limited basis, if you're working pre-hospital, you'll be administering it quite frequently if you work in a hospital. And I will tell you, the vast majority of your patients that are over the age of 55 are taking this as part of their medication regimen, is a class of medications called beta blockers, okay? What we're talking about here is, remember, we have beta 1 and beta 2 receptor sites. Beta 1 receptor sites are found where? In the heart. Beta 2 are found in the lungs. Just a reminder on the little memory aid. You have one heart, beta 1. You have two lungs, beta 2. Beta blockers block off the actions of beta 1. Okay, so when we stimulate beta 1, two things that really does occur is that we increase chronotropy and we increase dromotropy. Okay, now, Emily, What does the word chronotropy mean?
How fast your heart's beating.
Good. Excellent. Cece, what does the word inotropy mean?
Inotropy is like the flow,
Mm-hmm.
right? Or shoot, I forget.
Somebody help her out.
The force of the heartbeat.
Force of the heartbeat. Excellent. Yeah. Inotropy, if you think about in, out. Chronotropy is time. It's how fast the heart beats. For all the marbles here, dromotropy refers to what? Anybody?
It's the electrical impulses
What about them?
and how fast they get through the heart.
Bingo. Excellent. Good job. So make sure you're familiar with those. Beta blockers affect only two of these, chronotropy and inotropy. The primary reason that patients are on, two primary reasons that patients are on beta blockers is number one, to treat hypertension. It lowers the blood pressure. How does it do that? Well, it slows down the heartbeat and it slows down or it eases off the contractile force of the heart. Both of those together will help to drop the blood pressure. All right. And so it's very, very good for that. The other thing that beta blockers are given for is for a patient that has atrial fibrillation. Now, those of you that are in 303, we just covered atrial fib. By the way, those of you that are in 303 today, Professor Fiver had good things to say about you. So excellent. I already knew those good things, but now he knows about them, about you as well. So the fact that our patient is on a beta blocker helps to drop down the blood pressure, and it will help to regulate and make the heart rhythm more regular. It also reduces the workload of the heart, and wait, there's more. It helps to reduce oxygen consumption, which is extremely important when you've got a patient that is having an MI. We want to increase the oxygen availability, but we also want to reduce the oxygen consumption of the heart so that we reduce the workload and we preserve muscle. Okay? Beta blockers should go to all STEMI patients immediately. STEMI is an acronym for ST elevation MI. The only thing I want you guys to know right now, because we haven't covered STEMIs because that's in advanced cardiology, but the only thing I want you to be aware of is beta blockers should be given to all appropriate MI patients as soon as possible. Okay? I promise you'll see that question on an exam. It's that important. Generally, what we see is that beta blockers are given within the first few hours. If we can give them earlier, that preserves heart tissue even more. Who better to give a patient that's having an MI an early beta blocker than y'all as paramedics? You're there. You're watching this patient. Maybe they started having chest pain within the last 30 to 45 minutes. They call you. You're seeing it on the monitor. They've got all the signs and symptoms. And you say, here, take this pill. It's going to help preserve your heart. And we get that whole process started. The research is clear on this. The earlier that you give a beta blocker to a patient who's having an MI, the more heart muscle that is preserved. And remember, heart muscle that dies does not regenerate. It becomes useless. It doesn't pump and it doesn't conduct electricity, which can have a major negative impact on the patient's quality of life if we don't take care of those. You can give beta blockers either by mouth or you can give them IV. We generally don't give them IM. One of the things that you want to watch, and you will most likely give beta blockers IV if you're working in a hospital, is you want to watch their blood pressure really, really closely. Why? Because remember, it reduces chronotropy and inotropy, and one of the main reasons that I said that patients are prescribed beta blockers was what? One of the two? Why did I say patients were prescribed beta blockers?
For AFib.
And what's the other one, though?
Hypertension.
Hypertension. So we want to watch our patient, okay? We don't want their patient to drop down really, really low. The other thing, and this is true also for the administration of any type of narcotic. Remember, any medicine that we give that can drop the patient's blood pressure can also have a negative impact on the pumping function of the heart. So for narcotics and for beta blockers, we want to listen to breath sounds. Why do we want to listen to breath sounds? Because even though if we got a patient that's in heart failure and we give morphine sulfate and it reduces a preload, that will pull some of the fluid off. But if we give morphine sulfate and we either give too much or the patient has an exaggerated reaction to it, that pulmonary edema can actually get worse. Why for beta blockers? All right. Let me make sure you got everybody's attention because this is important. Beta blockers can cause bronchospasms. What are, from an anatomical perspective, what are bronchospasms and why can they kill our patient?
Spasm in the bronchioles.
And where do we find the bronchioles, Rebecca?
Before the lung.
So they're part of the lungs that lead into the alveoli. So if our bronchioles do this and spasm off, what's not going to happen?
O2 isn't getting in.
Yeah. So we can't get air in or out, which means what? We have made our patient hypoxic. Okay. The last thing you want your cardiac patient to be is hypoxic, because now instead of dropping the workload on the heart, we have increased it. And there's a good possibility that we will have a patient that we've made their MI worse. If you're getting your patient history and the patient tells you that they are taking cocaine, okay, you do not want to give a beta blocker to a patient who is taking cocaine. Basically, what happens here is that if this drug goes to work, and remember, it's going to block off the beta receptors. Now what happens is the alpha receptors, where do we find alpha receptors for this particular class that we're worried about? Where are the alpha receptors and what do they do?
Peripheral vasoconstriction.
So it leads to massive peripheral vasoconstriction. The blood vessels in the arms and the legs now begin to constrict. And when that happens, guess what? The blood pressure skyrockets. Not good for the brain, definitely not good for the heart. So giving a beta blocker to a patient that is taking cocaine is contraindicated. Contraindicated. Other contraindications that we're looking at here is number one, heart failure. Okay, heart failure comes about when the patient. Well, let me back up. Number one cause of heart failure is a patient who's had an MI. Okay, but I just said we want to give our patients beta blockers if they've had an MI. Okay, so Dr. Young, make up your mind. Do we give them or do we not? Well, if the patient already has a history of heart failure, remember, heart failure comes about because the patient has lost a bunch of cardiac tissue. It doesn't work. The last thing we want to do is that we do not want to depress the remaining heart muscle from contracting in and out, or being able to raise its rate. So we're not going to give our patients that are in heart failure any kind of beta blocker. We don't want to give our patients that are in cardiogenic shock, or for that matter, any kind of shock, a beta blocker. Why? Y'all should have the tools to be able to answer that one. Why are beta blockers contraindicated in cardiogenic shock? Cardiogenic shock comes about because the heart is pretty much done for. It's wiped out.
If you reduce the force of contraction and speed of the contraction, you're just going to worsen the shock.
So you take a really, really bad situation and you make it terrible. Excellent. Excellent. Good answer. Okay. If we've got a patient that's having an MI that's affected by a decrease in preload, don't worry about that one. Okay. If we've got a patient that's got a really, really long PR interval, now everybody should be familiar with that one. That's contraindicated. Why? Because that tells us we've got some kind of an AV block that's going on. For those of you that are in 303 right now, just put that right there in the front of your brain and remember it. When we talk next week about second degree type 2 and third degree block, that will become much more clear for you. Okay? We've already talked about the fact that we'll cover high degree block. Why asthma? Why are beta blockers contraindicated in a patient that has asthma?
Bronchospasms.
Excellent. What's the pathophysiology that causes asthma? Say that word again.
That's a big word.
No. The one you just said. Starts with a B. Bronchospasms. Asthma is caused by bronchospasms. So the last thing that we want to do is to have a patient that has a propensity to have bronchospasms, and we cause them to have a bronchospasm, and we induce an asthma attack. Remember, the primary reason that you as a paramedic is going to give a beta blocker is for what condition? STEMI, an MI, okay? The last thing we want to do is to cause our patient to have an asthma attack, which increases the workload on the heart and increases oxygen consumption, and again, could lead to the patient's death, also more commonly known as a PAD. PAD stands for paramedic assisted death. That's death caused by you or by me. We don't want to do that, all right? Now, the information that I've just shared with you is for that generalized class of beta blockers. But now what I want to do is I want to look at some specific beta blockers that are commonly used in the pre-hospital arena. The first one we're going to look at here is esmolol. Esmolol. One of the things I want to draw your attention to that will help you to identify certain classes of medication is the spelling, especially on the end. When you see a drug that ends with the letters LOL, no, that's not laugh out loud. That is a class of beta blockers. So again, if a patient hands you a bag full of medicine and you pull it out and you go, I don't know what this is. I've never seen of it, never heard of it, but you see that suffix on their LOL, automatically you know, oh, this is a beta blocker. Well, that explains why the patient has probably got a heart rate of 40, okay? Maybe they overdosed on their beta blocker. Maybe they accidentally took too much, okay? So esmolol is a beta blocker. We give it, again, to reduce inotropy and conotropy, all right? Your indication in here is going to be primarily for two things. ACS and AMI are basically the exact same thing. So if you have a patient having acute coronary syndrome, they're having an MI, an acute MI, AMI. So you can call it either one of those. The other thing that you will do with this, and you'll primarily do it in the hospital if you're working as a paramedic in a hospital, is we give it for patients that have had a rapid, sudden spike in their blood pressure. That's what the word acute means. Acute means sudden. It happened really rapidly. The word chronic means over a long period of time. So if I have acute chest pain, it's saying, well, I was fine a few minutes ago, but now my chest is hurting. If I say I have chronic chest pain, now what I'm saying is that I've had chest pain for a very long time. Years ago, I was coming back from Savannah. I had gone down there to do a site visit for a paramedic program, and I'd ridden my motorcycle down there. On the way back, I wrecked, and the only thing I remember was basically waking up in the back of a helicopter being flown to a trauma center. I had a slight head injury. Thank goodness I don't have any brain cells to waste, but I really messed my knee up, and now stairs are very difficult for me, and I have chronic knee pain. The fact that I'm overweight doesn't help that as well, but I have chronic knee pain, and that happened in 2016. That's a long-term thing. If I suddenly had chronic or acute knee pain, it would be, well, that's not normal for me, and now all of a sudden my knee is hurting. That's the difference between those two words. Now, when we're looking at this, some of the adverse effects, here we are, okay, drop in the blood pressure, it can cause bradycardia, can lead to heart block. Now, this is an important one here for you to remember. Hypoglycemia. Hypo means what? Gly is referring to what? Say it again. Glucose. Emia refers to what? Say it again.
In the blood.
In the blood. Okay. Hypoglycemia is low blood sugar. So if we've got a patient that is having a chest pain and their blood sugar is low, okay, we need to address that first and to get that blood pressure back up. Here's the other thing to keep in mind. This is going to be really important right here later on because we will utilize beta blockers for a particular type of overdose. I'm not going to talk about it now, but just understand that low blood sugar can cause a low blood sugar, and it's a side effect of esmolol in particular. Now, contraindications, these are the ones that we've already talked about. In particular, what I want you to remember is it's contraindicated in shock, in bronchospasm, and in pulmonary edema. Does everybody remember what I said pulmonary edema is? Does anybody need a refresher on that? So if I were to ask you to tell me what pulmonary edema is, everybody knows, right? Okay, I see heads nodding, okay? Again, we want to be careful with using it with patients that are diabetics that don't have really good control. Now, part of that problem is going to be, for you and I as paramedics, we're not always going to get the most accurate patient history from our patients. Not because they're doing something wrong purposely, not because they're trying to hide something from you. It's because they are not medical people, so they may not be able to tell you exactly what's going on with them. So you kind of want to watch that. One of the things I would encourage you to do, if you're going to administer, in particular, an IV beta blocker, check their glucose after you have given it. Okay? Do a finger stick and check their glucose to make sure that it's up in that particular dosing range. So basically what we want to do in here is the dosing is we want to give 500 micrograms per kilogram, and we're going to give this over 1 minute. The easiest way to do this is to draw it up and inject it into a 100 milliliter bag of normal saline and let it flow in as an IV. Okay, let it flow in as an IV over 1 minute. Then what we're going to do is we're going to follow this up with a dosing regimen that is a tenth of what we gave as the loading dose. We're going to go to 50 mics per kilogram per minute, and we're going to do that for 4 minutes. If we don't get the response that we want, we can repeat it again, except this time on the second dose, we're going to go up to 100 mics per kilogram per minute. Rebecca.
If a patient is already taking a beta blocker regularly, would you still give it or
We're probably not going to give them esmolol, but we will give them another beta blocker, most likely to take orally. This is one of the very few times that when you go out to get a patient, that you're going to give them anything to take by mouth. Aspirin is one of them. Nitroglycerin spray or a nitroglycerin tablet is another one. A beta blocker would be a third. So with this, because this is really quite potent, so basically that's the thing that we're going to be looking at here, is that this is probably not what we're going to be doing for patients that are already on a beta blocker. That's an excellent question. I want to come back to this and understand. What I want you to know is that the half-life of this is somewhere between 5 to 9 minutes, okay? What did we say a half-life definition is? So I'm telling you the half-life is 5 minutes for this drug. What did I just say?
that half of it will be out of the system?
Excellent, Cece. Yeah, very, very good. And how many half-lives have to pass before we consider it to be totally metabolized out of the body? 5. So in about 25 to 45 minutes or so, less than an hour, esmolol is metabolized unless they're taking it on a regular basis, and they have an extended type of release that they're taking on a chronic basis. Okay. Now, any questions on esmolol? Number one, know your dosing. Number two, know those indications, primarily AMI, acute hypertension, and in particular, know the contraindications there. Any questions on that? All right. Another beta blocker. How do we know? LOL. This one is called propranolol. Trade name is Inderal. Very, very common type of beta blocker. One of the most common uses of, let me ask you a question. Anybody in here ever have a history of migraines? You've got migraines. Have they ever prescribed Inderal for you for migraines? This is a common medicine that they will give to people that have migraines. When I was probably in my teens, my late teens, I had terrible migraines. And they would just incapacitate me. And once I got into my 20s, thankfully, I grew out of them. My youngest daughter is in her 30s now, and she still has migraines on a regular basis. And she has been on Inderal. And what it does is it helps to reduce the contractile force of the heart to help those migraines from occurring. But Inderal is also utilized as an anti-anginal medicine. What is an anti-anginal?
Anti-chest pain.
It's anti-chest pain as a result of a constriction of a blood vessel or a blockage of a blood vessel in a heart. Remember how beta blockers work. They reduce inotropy and they reduce chronotropy. When we do that, we reduce the workload of the heart. When the workload of the heart exceeds the amount of oxygen that's available, we have chest pain. Okay? If you and I have bills that exceed our income we have unpleasant experiences. It's the same principle. When the body has an oxygen demand that exceeds what is available to it, it has an unpleasant experience either also, and it is presented by way of chest pain for this patient. Now, the thing with Inderal is that it not only affects the beta 1, but it also affects the beta 2 receptors as well. Okay? It helps to reduce cardiac workload by reducing cardiac consumption. We've already talked about all these beta blockers reduce inotropy and chronotropy. So why do we give them? Well, first of all, patients will be on Inderal as a preventative type of medicine to help prevent them having anginal pain. So that would be one thing. The second one that I want you to know, don't worry about the narrow QRS tachycardia. We're not going to focus in on that one. The second one is if a patient has a history of hypertension. Not given as frequently anymore as what it used to be, but it's still utilized for hypertension. It helps to lower the blood pressure. And then the last one that we see in here is going to be for migraine headaches. Okay? Here's your side effects. Adverse reactions, adverse effects, and side effects mean the exact same thing. Can put a patient into a bradycardia. It can lead to a high degree heart block. Bronchospasm, especially with Inderal, because not only is it linking up with beta 1 receptors, it's linking up with beta 2 receptors that are found in the lungs. And it can drop our patient's blood pressure. Here's your contraindications. Any type of shock, any type of heart failure. If your patient is having symptomatic bradycardia, now what do I mean by symptomatic bradycardia? The definition is in its name. What does symptomatic bradycardia mean?
They're experiencing symptoms like
What would some of those symptoms look like, Cece?
probably like sluggish.
Yeah, sluggish, lethargy, chest pain, shortness of breath, dizziness. The other thing that we want to do here is we want to be careful if we're using Inderal with patients with COPD. COPD is chronic obstructive pulmonary diseases. It's a classification of diseases that primarily encompasses 3 diseases that includes 1, asthma. We've already talked about beta blockers in asthma. 2, emphysema. And 3, chronic bronchitis. All of those diseases have in common that they cause inflammation of the bronchioles. When we have inflammation of the bronchioles, what happens to the diameter of the bronchioles? Do they get larger or smaller?
Yeah, larger.
So the swelling grows, but with the diameter, the air passageway gets a lot smaller. It's in essence the same thing that we see with a bronchospasm in a patient with asthma. Different mechanism, same end result. Okay, so we want to be really, really careful when we're using it with patients with COPD. So here's your dose. If you're going to give it, all right, we're going to give 1 to 3 milligrams, and we can give it IV or IO, and we want to give it slowly. Why do you think we would be giving a beta blocker slowly?
So it doesn't just like plummet.
We don't want to bottom their heart rate and their blood pressure out. Absolutely. Okay. If you don't get the desired effect, you can repeat it 2 minutes later. Now let me ask you a question. How would you know if you're getting the desired effect or not? Again, why are we giving a beta blocker primarily?
High blood pressure.
High blood pressure or chest pain. So, how would you know if you're getting the desired effect for one of those 2 indications?
Blood pressure goes down.
Blood pressure goes down. Excellent. What would be another one for the chest pain?
They feel better.
they feel better. Their chest pain may not totally go away. You may still have to give them a narcotic, and quite frequently, you still have to, but their chest pain gets better. Okay, so those are the things that you're going to look for. Questions about propranolol? Third beta blocker, metoprolol, also known as low pressor. Now, when you look at that trade name, low pressor, what's it make you think of? What's this mean?
Low pressure.
Low pressure. Low pressure of what? The blood pressure. This is a very, very common type of antihypertensive medicine. You can see we can give it for angina as well, and many times patients will take it to prevent angina. But here's a big one. Hypertension. Hypertension, okay? Over in here, atrial flutter, not so much, but definitely atrial fib. So here's the thing. If you don't remember anything more than this, beta blockers are given for high blood pressure, acute coronary syndrome, and AFib. You and I will get along just fine, okay? Metoprolol will reduce oxygen consumption, saving cardiac muscle, okay? Some of the adverse effects you'll see with this is fatigue and dizziness. Why would that be? Why would your patient get tired and maybe even dizzy? What's the action of a beta blocker? Lowers the heart rate. Not so much hypoxia. Is that what you said, hypoxia? Not so much hypoxia. Slows the heart rate, and it does what else? Why do we give low pressure? Decreases the blood pressure. Remember, a slowed heart rate and a decreased blood pressure will do what to the blood flow to the brain? It decreases it. So if it works too well, or if we give too much, now the patient gets fatigued. They get tired. And this is not unusual for patients that have a new diagnosis of hypertension and they're put on medicine. It's kind of a trial and error type of process in which doctors will start out with a really low dose and they'll decide, okay, come back and see me in about a week to 2 weeks. Let's check your blood pressure, check it while you're at home. Let's see if it comes down. Many times patients will come back in and say, Doc, I am so tired. I can't even get out of the chair. Okay, so the doctor has a couple of options. Now, we reduce the dose even more, or we go with a different medicine. So if you get a patient that is complaining of fatigue and dizziness, ask them if they're on a beta blocker. Again, there is that bronchospasm. There is that hypotension that we've talked about. Contraindications. Use with caution in the same situations as we talked about earlier. Okay. Low pressure, fairly easy drug to give. We're going to give it 5 milligrams IV or IO over 2 minutes. Okay. Now we can repeat that drug dose up to a total of 3. With a total of 15 milligrams for this particular patient, okay? As long as we're giving it slow. Anytime that you are giving a beta blocker, your patient should always be on a monitor. You should be getting blood pressures every 5 minutes. You should be listening to breath sounds every 5 minutes or sooner. Okay, or sooner, right? And again, just like I have with all beta blockers, watch for bronchospasm. How would you tell if a patient is beginning to have bronchospasm? What would be one of the earliest indicators?
They're short of breath.
Even before that, that will come, but that will be a little bit later. There's an even earlier sign or symptom that you can determine?
SPOC.
Say it again.
SPOC.
SpO2 will drop right after the one that I'm thinking about. So it will happen very quickly with this one, but the SpO2 will be actually a second one.
Altered mental status?
That will also occur, but it'll happen a little bit later. Now, think about this. What happens when you have a bronchospasm in asthma?
Wheezing.
Say it again.
Wheezing.
Bingo. This is why we listen to breath sounds every 5 minutes or sooner, okay? And remember, when you're listening to breath sounds, you listen to them up here, right here, and back here. Why do we do that? Our lungs do not hang straight down in front of us. Your lungs, the top of your lungs start up here and they slant backwards so that the bottom of your lungs are back here. So when you're missing and you're not hearing breath sounds, almost always the first breath sounds to disappear or to have wheezing will be these down here. These up here may be nice and clear, but if you start hearing wheezing down here when it wasn't there before, your patient, your beta blocker is causing a bronchospasm. That's where I'm going to stop. The next drug we're going to talk about is atropine to speed the heart up whenever it is going too slow.